Hello, everyone, and welcome to another episode of the podcast. Today, I am joined by an expert in the management of tendinopathy. It is James Barker, or Jimmy. Jimmy has been a clinician for the last 21 years and teaching at Canberra Institute of Technology for the last 15 years. He is a soft tissue therapist and an exercise scientist, and he knows a thing or two about running and tendons. So let's dive straight in. Hello, everyone, and welcome. I'm so excited to be joined by James Barker. He is an expert in tendons and a fantastic manual So, Jimmy, thank you so much for joining me.
Anytime. All the way from cold Canberra. We've had a change today, and it's freezing as always.
Oh, well, it's beautiful and sunny over here in Perth, so hate to rub it in. But, Jimmy, we're going to be talking all about tendons today. So tendon research and the management of tendons, it's a really tricky environment, isn't it? And research has progressed and changed and evolved a lot over the years, but it certainly can be a frustrating condition to treat. So talk us through a little bit about tendinopathy. What is it? Is it tendinitis? Is it tendinosis? What is tendinopathy?
Well, I mean, tendinopathy really is the clinical term for pain and dysfunction. And you've got two kind of areas there. If you've got someone who comes in with an acute tendon issue, their primary concern is their pain. But if you've got someone who comes in with a chronic tendon issue, then it's much more about the dysfunction there. So they'll have pain, of course, but the dysfunction becomes really important. So what we need to consider is if someone comes in with an acute on chronic condition, we need to address their pain, but we really need to address the dysfunction. And so a chronic person will come in with changes in the brain. So the brain will downregulate the ability of the tendon to store and release energy. There'll be changes in the muscle. So the muscle will lose stiffness, and you normally find some atrophy in the affected muscle tendon unit as well. They'll have changes in the ability to store and release energy. So you get less of that spring activity, and it'll be really quite it becomes more flexible, if you like, for lack of a better term. But you also get changes in the whole kinetic chain as well. So for us, being manual therapists, I find that we're well placed to treat things like the kinetic chain. So, for example, if someone comes in with an Achilles tendon injury, we need to look further up the chain and say, okay, well, what are the hips doing? What's the knee doing? And why is that muscle tendon unit not functioning as it could be? So when you get changes in the kinetic chain, you're going to get some compensations as well. And the classic example is, and it's an easy one to demonstrate, is the one where if someone comes in with a big Trendelenburg on, say they've got a right side Achilles issue and they've got a right side Achilles Trendelenburg where they're really dropping out, their glute med function's not doing so well, we'll find things like the TFL really increasing their tone to try and take some of that stability away from the lack of function from that glute med. So we can go in and use some of those soft tissue techniques, improve the ability of the kinetic chain to function better, which then helps things further down the chain. So we're really well positioned to treat that sort of stuff. With your question on tendinitis and tendinosis, that's really interesting. I mean, tendinosis talks about the actual structural change in the tendon, but it doesn't really help us with our management. So tendinosis isn't a term that we did use it back in the early 2000s, but we probably want to steer a little bit away from that, knowing that it's there and knowing that it occurs, but it doesn't really change or help our management. So we tend to steer away from tendinosis. Tendinitis is really interesting. Now, we don't call it tendinitis because that implies that we'd use very much a passive approach. So we'd use our rest and we'd use some anti-inflammatories and some ice. So we want to stay away from that term as well. I'll get to peritendon later because we can have what we think might be an inflammatory condition in the peritendon, but that's probably I'll leave that for a few minutes time. But we know that there's pro-inflammatory markers in the tendon. We know that it's sort of coming back around from 20 to 30 years ago, but it doesn't change our management. If we had someone who twisted their ankle, gone off the curb, done their ankle, that's very much in the first few days. That's a bit of a passive intervention, becoming more active as we progress through. But with an Achilles tendon, knowing there's pro-inflammatory markers, but also knowing that it doesn't change our actual treatment approach is probably very important. So both of those, itis and osis, are probably things that we probably should steer a little bit away from, but just knowing that doesn't change our treatment, because we really need to think about what tendons respond well to is load, and we have to get some load on them as early as we can without provoking their issues.
Yeah, and I think that's a really important point there, isn't it? That it's a load-based presentation, and therefore the term associated with itis, inflammatory response, may be interpreted to rest and completely deload that area. And you touched on some great points around the kinetic chain. And if we've got a local area of sensitization or pain, and we completely deload that area, well, it also deloads the rest of the kinetic chain, right?
Yeah.
So we've got to consider, broadening our lens that little bit.
Yeah. I mean, sometimes with some people, and this is where the confusion can change, is you'll actually come in and you'll have an increase in the range of motion in some people. And as soft tissue therapists were always said, oh, you've got to get the range, you've got to make sure you treat it. But for me, I'm actually happy to have someone who's got a little bit less range, but nice and stiff and can function through those tendons in whichever tendon we're talking about, of course. More so in the anti-gravity tendons, and that's sort of from the hip down, as you know, is what I focus on. There's no shoulders for me. But it's the anti-gravity tendons that really need to be robust and spring. And so to have, particularly things around the ankle, to have a little bit less loss of range of motion there, or less, is okay as long as you can function well. Yeah.
That's so important, I think, to take that away, that the stiffness and springiness, because often patients might describe, oh, it feels really tight, I feel like I need my calf released. But and it would sound a little bit counterintuitive to say, well, let's load it up, let's do some heavy slow resistance training to start to bring some capacity back through there. But they go, but wouldn't that tighten it up more? And so but that's actually what we want. We want the stiffness through the tendon.
Yeah. And so what you'll find a lot, and this is probably mainly talking to the Achilles tendon with the calf here, is you'll find a lot of people come in, it's really prevalent through middle-aged males, particularly, is what I see. I mean, it happens across the lifespan, of course, but you get middle-aged males who go, oh, I might want to go and play a little bit of soccer on the weekend, or do something a little bit more explosive. And they come in with where they've had lots and lots of calf tears. And what actually happens is you have a change in the neuromuscular drive in the calf, which then affects the muscle tendon unit to spring. So probably for me, the only time I'd use manual therapy on the posterior calf, so the gastroc and the soleus directly, is if I palpating through that calf, or they can tell me that they've had lots of tears over the time. That's going to reduce the capacity of the calf to operate at its maximum capacity, and so therefore you're going to have that reduction in the ability to operate like a spring. So in terms of manual therapy, I would only go to the posterior calf in the cases where there's it's really grotty, there's scarring and all that sort of stuff, just to mobilize the tissue so I can actually get better function out of the calf. But I think as soft tissue therapists, we can do better than just going, oh, well, you've got an Achilles, or you've got a patella, or you've got a hamstring tendon issue. I think we can do better than just going to that muscle and rubbing it. It's not really about that. It's about going, okay, what's your dysfunction? What can you do now? What do you want to get back to? And how can I get you back to that position? So I think gone are the days of just going, all right, you've got a sore bit here, I'm just going to rub it. We can't be doing that. We've got to be a bit more getting our diagnosis right.
Yeah, it's got to be goal orientated, doesn't it? Get them back to what they enjoy doing, those meaningful activities. And so I guess those meaningful activities for some people may be the reason that they present to clinic. So what are the common causes of tendinopathy?
Well, broadly speaking, you've got two really broad things. You've got overload and you've got underload. So in an athlete population, or even a weekend warrior population, you'll have two types of overload. You'll have the acute overload, might I say that acute overload is quite a real acute tendon is quite uncommon. You'll get a chronic overload, but you'll get the really common ones are where you've had a grumbly tendon for ages, and then someone's done too much and they've got an acute reaction on a chronic issue. So we call it acute on chronic presentations. They're the overload issues. The other ones that are probably harder to treat, in my opinion, are the ones that are chronically underloaded. And they'll always, if you have, we know if you have even 2 weeks of unloading a tendon, it will reduce its stiffness. And so even if you go back to your normal exercise load, that is actually now an overload. So it actually is, it's not very good for it. So that's when you tend to get problems. But the hardest thing with people who are underloaded are those who've got comorbidities where they're on statins, they're on blood pressure medications, they've got some central adiposity. All those things affect tendons. They affect the biology of the tendon in not a good way. And we generally know that those people, if you look on the health history question and you go, oh my goodness, they've got blood pressure, they're on statins, you know that they're probably going to take longer to respond, and the tendon doesn't like changes. Tendons don't like changes in general, but people with these kind of comorbidities really don't like changes. So we know that it's going to be a longer treatment process for them. So we've got overload, acute and chronic. We've got underload. We've also got a lot of other things that affect tendons. Age affects tendons as well. Years of training will affect tendons. That's positively, but also negatively as well. So some people can have, months and months and months of volumes of training, and all of a sudden they just go, oh my goodness, I've got a problem now. And it's just where the tendon said, I'm just meeting the demands, but now I just can't do it anymore. And I'm going to let you know, and I'm going to give you some pain by doing that. So there's a whole lot of other things that can affect. Hormonal factors are now a big thing, particularly with gluteus medius tendinopathies with middle-aged females primarily as well. So there's a whole lot of things that can affect it. Yeah.
Yeah, and that's why it's important to set those realistic expectations, isn't it? That it's not just a 4, 6, 8, or 12-week fix. It's, there are these various influences such as genetic factors, as you mentioned, central adiposity, hormonal influences, age, history of sport, all of that sort of stuff. And so we've got to factor that into the overall prognosis and management as to say that, this may take 6 months, 12 months, and it's just going to be working with those symptoms and getting it to a manageable point where we can integrate those activities, right?
Yeah, absolutely. I guess one of the things for when you've got a patient is giving them realistic timelines as well. This isn't going to be something that's going to be a couple of weeks. You don't necessarily, in my opinion, need to see that person every week, but you do need to make sure you keep tabs on their progression of load. So what I would normally do is I might see them once or twice in those first couple of weeks. And then I normally say, look, come back and see me in 3 or 4 weeks. I'll give them stuff to go away with and give them progressions to go away with as well, but also regressions in case they have a bit of an upset and things to look for. But I always say that tendons will let you know, generally speaking, how they go, but they'll tell you the next day. They're like a delayed text message. They take a little while to get through the network, and so they'll always let you know, just possibly not at the time. So making sure that they actually know how to monitor is probably one of the most important things, but also letting them know that, hey, this is not 3 months, it's probably closer to 6 months. You don't need to come and see me every week, but I do need to make sure that we progress you in such a fashion that you're always increasing. And that's probably where the compliance is the biggest issue, is where people, the old term of I haven't been very good with my exercises translates to I have not done them at all. So, and we've all heard that one.
Yeah. But I think you're right. I think that's one of the biggest mistakes that's seen in practice is not loading the tendon appropriately. And so if those exercises aren't progressing, especially, if you're looking at that energy storage and release, running, jumping, that needs to be progressed, where it might start in those early stages with that heavier, slow resistance training. But sometimes people are stuck on just a unloaded double leg calf raise for 6 weeks, and it's sort of like
Yeah.
that really needs to jump up a little bit. So I get what are some key tips that you've got there as far as load management and progression in clinical practice?
Well, that's completely right. You can't stay on body weight exercises, and as good as isometrics can be, and we know they don't work for everyone, but as good as they can be for some people, they're also a starting point, not an end point. So if someone does want some pain reduction and the isometrics do work for them, you probably, broadly speaking, you probably don't want to be on them for much more than 2 weeks. Certainly not more than 2 weeks if that's the only thing that you're doing. You can incorporate those for a bit of pain reduction if they do get a bit of a spike in pain along the way. But we could start with isometrics. We could start with concentric, eccentric. If you're starting with things like for the Achilles, for example, a double leg calf raise, you want to get up into a single leg calf raise. You really want to be getting up into some really heavy, slow resistance training in the start to actually get them to really load the calf in a safe position. Generally, what we find is heavy, slow calf raises will actually reduce tendon pain as well. So you don't have to do isometrics to get a reduction in pain. Those will also do a similar thing. We also want to make sure that this is where it gets challenging. I find that most people will get some reasonable results after a period of doing some heavy, slow resistance training. So much so that most of them are like, "Oh yeah, I'm pretty happy with it." But if you've got someone who really needs to do higher loads, then you have to take them to things like where they're doing a little bit of light hopping. So I'll do some little sort of reps of 20 or 30 just double leg. Then I'll go to single leg hopping. And then I might get them to go to forward hopping. Now, by the time you've got them to going into forward hopping, they're probably returned to ready in the population that I treat's a lot of runners. So they're probably ready to start running because it's the same sort of load. So if they can hop 10 times pain-free, and they're pain-free the next day, I'm pretty happy for them to start. But we do need to get them to go strength, then some energy storage and release, and then looking at return to sport. We can't start on double leg calf raises. We can't just start on some glute hitches or single squats for glutes and just have them doing that the whole time. We have to progress. It's exactly the same as going to the gym. You go to the gym generally to get stronger, and to get stronger you've actually got to up the weights at some point in time. And so we have to do the same if we're looking to rehab a muscle tendon unit effectively, very much so.
Yeah, and be consistent with it. And
Yeah,
so I think so. I guess if we've got a patient presenting to clinic, and runners, they are, I learned pretty early on, they can be very difficult to treat
yeah,
as far as modifying load. So if you've got a runner that presents middle-aged male, for example, and moderate Achilles pain, but they can run 5 kilometers. What's that sort of look like in practice? Like, do we need to completely stop them from running, or where do we go from
yeah.
there?
Good question. What we need to do is we need to find what the provocative load is. Now, for them, the provocative load with runners is mostly it's mostly things like speed training, which is higher intensity, so it provokes the tendon ball. And there's also things like hill running as well. So if we can identify that provocative load and modify that, I don't want to take them completely off running unless they're absolutely hobbling and basically running on one leg. So I want to keep some load on. So what I normally say to them is, over the next week, find what your provocative things are, take those out and see what your baseline levels are the next day. Now, I don't want you to tell me so much how you are after the run. I'm more interested in the next day pain, because that'll tell you if you've done too much. You'll know if you've done too much on the Thursday if you wake up on Friday and you're really sore, and then that's the chance to modify it. So you haven't gone completely backwards, you've just got to modify things a bit. Once we get a baseline, and for me, I tend to go with a baseline of 4 out of 10 or less pain is pretty good. Now, that's obviously very subjective, and that's their 4 out of 10, but you have to trust them on that. And if I can get them to that, then I can just start to add in a few things, making sure that next day is okay. The only proviso with that is thinking about things like peritendon issues, which the difference between a tendon substance issue and a peritendon issue is the peritendon will actually get worse as you run. So typically tendons will start off a little bit achy, and as you progress through a run, within 5 to 10 minutes, for most tendons, they're actually going, oh yeah, it's pretty good. I like movement. This is pretty good. But if you get a tendon that actually starts off okay and gets worse throughout the run, it's probably a friction issue. Now, friction issues are really hard because a friction issue you have to unload, and you have to unload it quite aggressively. But it gets to a stage where you generally get some good changes with unloading with the friction issues after about 2 weeks, but it's also at the point in time where you start to lose some mechanical stiffness, and so you're also getting into the area where it's starting to affect the tendon substance as well. So we have to get the peritendon sorted, then we have to then start to gently reload. But the way we reload those things is we have to do them we can't go just do heaps of calf raises because it gives it heaps of friction around the tendon. So we have to do sort of things like isometric, where we might do some walking on the tiptoes up the hallway or something like that, where we're still getting some load through them, but we're not doing heaps of long holds, and we're not doing lots of friction. So the peritendon can be quite difficult to treat. And then normally things like where you don't actually have a lot of ground reaction forces, if things like swimming can do it a lot because they're sort of in that mid-range with the kick. Cycling, where they foot drops down off the pedal, lots of friction through the tendon there. Running can do it. As you get more fatigued, you spend more time on the ground and more time in the mid-range and just going through that motion repeatedly. So lots of those things can produce issues as well. So the peritendons are, in my opinion, harder to treat. You don't see them as common, but they're harder to treat.
Okay, so we've got the peritendon, we've got the tendon substance, mid-substance to consider. So I guess, how do we assess this in clinical practice? I know that you sort of mentioned some key things with history, but what's a physical assessment look like, and what are the different differentials to consider?
Yeah, that's a great question because, I mean, for all tendons, there's always differentials. I think probably one of the first things is to look at your person and look at what's actually provoking them as well. So if there's someone comes in to me and says, "Oh, look, I'm doing a lot of bike riding and I've got a tendon issue," I know it's it's probably very unlikely to be a tendon substance issue. So I'll probably think about right there and then that's going to be something like a peritendon. Same for patella tendon. If someone comes in and they're doing lots of riding, a triathlete or a rider is not going to have a patella tendon issue. It's going to be young jumping men or people in basketball and volleyball, that sort of thing. So look at the sport. Differential is really important. For Achilles, there's a huge amount of things that can be around the ankle that hurt, like a tendon does, but they're just not a tendon issue. So you can have things like your sural nerve, you can have fat pad issues, you can have plantaris issues as well. You've got your mid portion, your insertional, your peritendon. You've got a whole lot of issues that it can be. So making sure we get the right diagnosis and through the right assessment is really important. So what I'll normally do is I'll start them off on a loading activity. The important thing about loading is that when you've got a tendon, and this is for most tendons, it's super localized pain that doesn't refer, generally speaking. We've got things around the glutes and the hamstring, which gives a little bit of referral, but it's not massive. It's normally super localized pain that only hurts on loading or compression. And it hurts as you increase the load more, the pain goes up with that. So for example, if I take them to a calf raise, or I take them and it doesn't hurt, and then I take them to a single calf raise and it hurts a little bit, I'll then take them to a hop, the pain should increase. And if I take them to a short hop, the pain will increase again. So the pain goes up with the amount of loading that's placed on the tendon, and that will be the same for a patella tendon, for a glute tendon, for a hamstring tendon. So they always do that. So we really need to make sure we get our diagnosis right. We need to make sure that we load them in the clinic, and that also that loading in the clinic will give us a baseline. So if I find that someone's getting a little bit of pain doing a calf raise, I know that I could probably take them in. That's their starting position for their exercise to go away with. And I'll be also looking at how they spring. So a lot of people will with any tendon, they'll sort of hit the ground and they won't want to bounce up. They'll just hit and they'll fall. So they lose that spring. You also notice with any issue with a tendon, you'll find the muscle tendon unit, so quads for patella, calf with Achilles, glutes with glute med tendon, they'll all have some atrophy there. And we want to address that atrophy and make sure we get that muscle tendon unit firing again. And they'll have changes in the kinetic chain as well, so that you can take them through all the usual kinetic chain assessment we do and look at those and keep coming back. And when you get them back in the clinic, come back to those things that were giving them problems. Say, now, can you do this? Can you do the hop again? Can you do your bridge test again?
Yeah, that baseline testing is so important. Otherwise, we might be starting 6 to 8 weeks back from where their current capacity is. And so for progression and moving forward and those basic S&C principles of progressive overload, we've got to get that baseline right. That's great, Jimmy. So I think that's a good place to start. And there's obviously a lot of differentials to consider in your assessment. But can you talk us through the whole warm-up phenomenon? Because often patients will say, oh, I've had it for quite a while now, but once I start, it's all good, it goes away, but then it gets a bit worse afterwards. What's going on there?
Yeah, I don't think we completely know what's going on there, but we do know that tendons do warm up, and this is where some of the problems lie. Is people go, oh, it actually started and it was a little bit sore when I started, but got going, it was okay. And that's the perfect time to actually do too much. So we need to have an idea about how much we're going to do, and how much we sort of might need to set ourselves with a limit. So most people will say, oh, look, I started out, it was sort of like a 4 out of 10 pain, and it dropped down to a 1 out of 10 pain. And that's a good thing. But what you need to look at is how you respond to the next day to know whether you did too much. Okay, so we're more interested in when you got up in the morning, what was your AM stiffness like? Was your stiffness better? Was it worse, as a means to actually then progressing that person? That's about the 24-hour monitoring the next day pain sort of stuff. As I said before, the peritendon stuff doesn't warm up. It gets worse because there's constant friction on the actual thing. We don't actually know what causes the AM stiffness. We're not sure where we're stuck with tendons is we know that when you've got a structural change in the tendon, we actually know what you have to do to get a tendon injury, but we don't know what the produces the pain. We've gone through lots of ideas going, oh, it could be neovessels, it could be, the blood vessels and nerves growing in there, it could be substance P, it could be glutamate. There's a whole lot of things. We don't actually know what causes the pain. This is where a lot of the biologics are headed to try and figure out that. But at this point, we don't actually know what produces the pain, which it makes it a little bit hard in some ways.
That's a real challenge, isn't it? And we see that disconnect between what we see on imaging versus clinical signs and symptoms. And, we see a lot of imaging that would say degenerative tendinosis and, there's all these changes within the tendon. But some people can have absolutely no pain with those same changes. So I guess how important, if a patient's thinking, well, I've got a degenerating tendon, I'm not going to load or run on it because I don't want it to break. What do you think about that?
Well, and this is probably a big issue because, and this is no discredit to any of the GPs, but a lot of them will say, look, you just got to rest. And there is no two ways about it. If you rest your tendon, you will not get pain when you rest. But anything you go to will then be an overload, and that overload could be really, you might only walk a couple of K, because what will happen is you would lose that any muscle tendon stiffness you had will be lost even further. So it's the overload coming back from the underload, which is the real issue that will cause the problem. So rest is probably one of the worst things you can do to a tendon. But you also, if you're relatively immobile, you'll start to get increased cross links through the area. Your blood sugar levels might go up, and sugar has a really high affinity for connective tissues, and it loves to store itself in the connective tissues. More cross links, less capacity to act like a spring and store and release energy. So you start to get some real issues there. So of all the things you could do, probably rest with what we know in this point in time, and don't see that changing, I think is probably one of the worst things you could possibly do. And look, that's relative, because some people might find that just going for a little walk, some people might find going to the gym is enough to do something, but you've got to keep some load on the tendon. Some of the issues are as if you've had some surgery and you're stuck in a boot, and that becomes very hard, of course. So, and that's probably why they stage you out of boots as well, so you can actually get some load on some of the tissues afterwards. But we don't want to be resting. We want to keep load where we can on the tendon to the capacity that you can without stirring it up. And for some people that might be only a little bit, and for some people it might be quite a bit, but we've got to expose those tendons to load. Otherwise, they've got nothing to respond to. It's almost similar to a joint in that if you've got joint issues, as long as you can load it without creating more pain and more dysfunction, then it's going to be generally good for that area.
Yeah, fantastic. So what's a return to run program look like? If sort of a basic, if someone's had quite severe Achilles pain and that's all then been managed, like how does integration back into running, what does that look like?
Well, running's probably one of the easy ones. Well, what we don't have at the moment with a lot of sports is we don't have markers for return to sport markers, but running's one of the few that we consider that probably does, in my experience. And for me, it's like, and this is the same for a calf strain or an Achilles, and they're kind of integrated, because if you've got some changes in the calf muscle, you have changes in the tendon. So what I like to be able to make them do is I like to be able to get them to hop 10 times in a row. So hop, 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 hop 10 times in a row, completely pain-free, with good spring, and making sure that they're not stirred up the next day. If they're able to do that, I know that they're actually able to start running. My return to running will be very conservative. I'll normally get people to say, look, go on your normal 20 or 30-minute walk, if that's what you're doing. And I'd like you to do 5 by 1 minute jogs. And I'd like you to do them slow. And I'd like you to do them not on any hills. I don't want hill rips at the moment. And I actually like them to do it on grass if possible, because what happens on grass is grass will actually increase concentric load and activity on the calf. And if we can do that for an Achilles, that's a great thing to do. So we want to be able to, once they can do 5 by 1 minutes, I'll just go 5 by 90 seconds, and I'll probably do 2 sessions of each. So rather than taking them up every single session, I'll go 1, 2, then hop them up, 1, 2, hop them up, 1, 2. So they actually stay there for more than one session. So we're not just going up and up and up and up and up, because that's where tendons get into trouble. And that's where we've got to go, okay, if you have a day of upset with tendon, that's not an issue. But if you start to have 3 and 4 days, that's where we're going, oh, that's too much. We need to back off. We need to modify it a bit. So there's always this sort of, how are you going? Are you going well? Are we doing too much? It's a real, and no one will ever go perfectly. It's always like this. And so you'll always be just managing things. Okay, take this back a little bit. Let's actually chuck some isometrics in there. Let's get some isometrics on to increase some of that calf drive. Then let's do your calf raises. Let's do some jumps as well. So really starting to progress them. So there is no one way, but it really does depend on the person that comes in. Yeah.
Yeah, definitely. And I guess if we're looking at a runner's program, do you think that it's important to maintain some strength work during their normal week?
Absolutely. You took the words out of my mouth. Yeah. You've got to, I think what the really important thing is when you move to some of the more dynamic activities, is they always say that a couple of times a week still keeps them slow, heavy resistance, because that's the underlying strength and it's the underlying mechanical stiffness. And that's where we want to hold those baseline levels while you're going up and doing other stuff. So it seems fine for most people. Once they've got to a reasonable level and they're happy with their activity, it seems fine to actually just do twice a week. I will say that I find that humans being humans, once they're pretty good, they're like, oh, cool, my Achilles is better, my hamstring's better, my whatever's better, cool, I'm going to go and do my stuff. And they forget about it. that's human nature. But it's just important to let them know that when they do drop the strength, the tendon will return back to normal. It will only be a matter of time before it does actually reappear. It's just the biology of the tendon, so it does need to be maintained. If you listen to Jill Cook stuff, she'll say that you need to maintain your calf strength forever if it's an Achilles, your quad strength forever if you're a jumping athlete. So it is something that needs to be maintained.
Yeah, okay. All right. And so, Jimmy, I know that the tendon management's looked a lot different in the past. So how has that changed to where it is today in 2020?
Oh, this is cracking. I mean, really. So what we had in the 1990s is we did go, oh, it's tendonitis. We'll treat this as a passive intervention. So we used to do rests, ice, elevation, anti-inflammatories, and guess what happened? They felt good when they were resting. They got better, and they started doing their activity again, and they got sore again. So there's lots of athletes that actually had career-ending issues with certain tendon issues. So that was the 1990s. Then came Hacken Alfredson. Everyone's heard of his story where and he's still a big hitter in this area. He wanted to get he had an Achilles issue and he wanted to get it fixed, and I'll just jump to the head of the line because I'm in work in the sports department. No, everyone knows me, and they said, you get to the back of the line, mate. You got to go with everyone else. He said, right, I'll show you guys. I'll rupture my tendon. Then you have to get me in quick. So he started doing heavy eccentrics. So up on 2, down on 1 on the affected leg. Now, when you consider how much he did, he really was having a crack at rupturing his Achilles. He was doing 3 sets of 15 reps of straight leg calf raises in the morning, 3 sets of 15 reps of bent leg calf raises in the morning. That's 90 reps. And he'd do it again in the afternoon. So he's doing 180 reps a day. And after a period, he first got quite sore. He's like, yep, I'm on the right track. He started to get a bit better. It's like, oh, I'll show you, put on some more weight. Got heavier and heavier. Until after about 8 weeks, he's going, oh my goodness, I'm actually getting better. So he did a 12-week intervention on himself and went, this is actually working. Got 15 people who are on the list for surgery, took them off, put them on this intervention. 14 people got better, and a year after was still at so much better that they didn't actually have surgery. One person did go on to have surgery. That started the whole eccentric thing. That was in 1998 that he published that paper. So we went along with that, and that was going pretty well. But then we started to look at other things. We looked at imaging was becoming really popular then, and we're looking at holes in tendons, and we're looking at sclerosing blood vessels that weren't supposed to be there. That hung around for a little while. Jill Cook and Craig Purdom then wrote the cell-based continuum model, which is still around today and still does have some real relevance for us. But then we got into 2015, we got into the whole isometrics, which looked good. It's been reproduced in some studies, but not all. And the thing to take from that, and look, Ebony Rowe is one of the leaders in the world of this, but we know that that her study only had, I think it was 6 people in the original thing, but she really has changed the way we think about tendons, which is such a great thing. And she's a good clinician, and she's also a really nice person, having had the pleasure of meeting her a couple of times. So she's changed things. I think now where we are is imaging plays a much less of a role. There is a side of sports physicians and groups looking at the biologics and how we can help the tendons. They're probably looking at more about what is the pain and how can we change that. So things like shockwave therapy is in that, and PRP is in that as well. Corticosteroids have really, well, we shouldn't inject those into tendons anyway, but they sort of sit over in that sphere somewhere. And then we've got the real exercise load over here. So we've got real 2 distinct areas looking at tendons from a different position. But there's lots to learn. I don't know where it'll go. I don't know what we'll be talking about in 15 years' time, but we'll know more things about the tendon for sure.
Yeah, that's interesting, isn't it? When we've got, people that were all in the eccentric loading, then it was all isometric, and then is concentric better, eccentric better?
Yeah.
Heavy, slow resistance. And so, Yeah, it's such an evolving space, isn't it? Tendon management, and
Mm.
as you said, we still don't really know what causes the pain, but we know that it's a load-based presentation, and loading tends to
Mm.
respond really quite well.
Yeah.
So, is there anything else that we needed to add in today, Jimmy?
Oh, I think I probably pretty much covered it all. Yeah.
Yeah.
Yeah. I mean, look, it's an area that I find really interesting, and I hope people do. But probably one of the most important things is make sure you do you do a really good initial screening on your person. Make sure you get your diagnosis right. Look at all the differentials around the area, whether it's hip, ankle, knee, foot, whatever it is, because you can only manage tendons properly if you get the right diagnosis. And if it's something else, then you're going to go completely down the wrong track, because there's a lot of issues where if you load and it's not a tendon, it can make it worse if you don't know what you're doing. So that's important as well. And I think that's probably in our industry, I think our assessment could be better. I think we probably need to be upskilled on that to make sure that we can pick the right presentation, because you can't treat a presentation if you don't know what it is. Yep.
That's some great advice there, Jimmy. You're such a wealth of knowledge. It's always so nice to talk to you. Thank you so much for your time. I really do appreciate it.
No worries. Thanks, mate.